Hi, this is Dr. Eric Donor, and today we're going to talk about spider veins. All right, so spider veins are those red or blue veins on the legs that just don't look good. They're always considered cosmetic. In the past, the insurance companies would pay for them. Guess what? That's no longer the case. They're considered cosmetic and they're always self-pay. All right, so how do we treat them? Well, sclerotherapy, or injecting the veins with medication to seal them shut, is still the best way to do it. Why is it? Well, we do have lasers that can help treat them, but the lasers are much slower, more uncomfortable, take a lot more treatments. So when we're using sclerotherapy to take care of spider veins, we're injecting them with an FDA-approved medication called polydecanol. Polydecanol is the most widely used substance in the world. It's approved by the FDA. It's very safe. It doesn't hurt because it was originally developed as an anesthetic. Okay? And so what it does is it irritates the inside of the vein, seals it shut, can't carry blood, can't see it anymore. Unfortunately, sclerotherapy is a process. It's not like an overnight sensation where the veins vanish and never to be seen again. It takes a number of treatments. The number of treatments it takes, it depends on, one, how bad the veins are in the first place and how motivated you are. If you want to have legs that look like a 17-year-old, that's going to be really hard to do. Not impossible, but really hard to do. And so the way it works is you come into the office, we clean off the legs, take photos, do a consent form, and I'll talk about the potential complications in a minute. And then we start injecting the veins in certain areas, and the bigger veins get injected with a stronger concentration, the smaller ones get injected with a lesser concentration. We also look for something called feeder veins with the ultrasound. So the ultrasound can find veins underneath the surface feeding into big patches of veins, especially on the outside of the thighs or the inside of the knees. If we see those, we inject them as well to seal them shut so you get better faster. After the injections, the veins are going to look like a cat scratch. They're going to look raised, red, irritated. They can sometimes be a little itchy. All right, that'll settle down. If they're bulging veins, we will put you into support hose. Otherwise, I don't make you wear them. I do insist that everybody use a cream that we have here called Dermica. You rub it in 2 or 3 times a day into the vein areas that we treated, and it helps with bruising, helps you get better faster, and it helps prevent some of the complications, which I'll talk about in a minute. Then we wait, because this is a process that takes time to see improvement. You return in approximately 2 weeks for the nurses to look for something called trapped blood. Trapped blood means old dead blood in a vein that has been sealed shut, but it's just sitting there. And so the nurses find that and they poke it, squeeze it out, get rid of it, and you get better faster. Sometimes it can feel a little red or hard in that area. It's not a blood clot, it's just trapped blood. All right. Then you return in 4 to 6 weeks and we treat you again. So, how many treatments does it take? I always tell people minimum of 2, usually a minimum of 3 sessions to see a 60 to 70% improvement, and that's if you have not a lot of spider veins to take care of. Now, you will grow more spider veins in the future. Everybody does. You just like to grow veins like everybody does. Okay, so most people are back in 18 to 24 months for a single touch-up treatment. So, what are the potential complications? There's 4. The first is a blood clot. That risk is 1 in 50,000. If you do get a blood clot, you will have to go on blood thinners for approximately 3 months. In the 17 years of doing this, I've had 1 blood clot, and so that was in a person who had an underlying clotting disorder we didn't know about. The second risk is an ulcer. I've never personally seen an ulcer or made an ulcer. That occurs when you potentially inject the medicine into the skin instead of into the vein. That happened with the old-fashioned hypertonic or saltwater solutions, which nobody uses anymore that knows what they're doing. The third risk is matting. Matting means when you sometimes inject a vein, you will sometimes stimulate the production of other little tiny veins in that area. That either occurs because of some inflammation going on or because I missed a feeder vein into that area. So we look for feeder veins and inject those. The fourth risk is the most common, that is hyperpigmentation. That means a brownish discoloration where the veins were. This can happen with the darker blue veins, not the tiny little red thread veins. If we see hyperpigmentation, we put you on that Dermica cream I talked about, look for trapped blood, and wait. The way to prevent hyperpigmentation is don't go out in the sun and suntan or tanning beds or go to Florida right afterwards, okay? If it does occur, It is temporary, but by temporary we mean 3 to 12 months. All right, so what do we use? So people say, ooh, it's a needle. It's a tiny little insulin needle. It's very tiny. You will barely feel it, I promise you. All right, this is Dr. Eric Doner talking about spider veins. Hope to see you soon.